Hello, everyone. We've finally come to the end of our lecture on effective hypertension management strategies for older adults. After exploring the various studies conducted on the management of hypertension in the elderly, we can come to the following conclusions. With the high prevalence of hypertension among the elderly, morbidity and mortality from hypertension is expected to increase. It is clear that treatment is beneficial in this population. Make the diagnosis with serial measurements, at least once checking blood pressure in both arms. Look for cases of pseudohypertension, mass hypertension, and situational hypertension. And if available, consider ambulatory blood pressure measurements to help identify situational hypertension. Exclude secondary causes in cases of resistant hypertension. Remember, the main aim is to delay or mitigate organ damage secondary to hypertension. Consider potential adverse effects of your treatment, especially in frail patients, as determined by slow gait speed, poor grip strength, signs of functional impairment, weight loss, or exhaustion. If non-pharmacologic intervention have not been successful at lowering blood pressure to target, we recommend a long-acting dihydropyridine calcium channel blocker, unless there is comorbid diabetes, ischemic heart disease, or chronic kidney disease, in which case an angiotensin converting enzyme inhibitor is preferred. Monitor blood pressure frequently after therapy is initiated and include home measurement in your decision making. In follow ups, ask questions about low tissue perfusion, orthostasis, and falls. Target an initial systolic blood pressure below 150 mm mercury and a diastolic blood pressure below 90 mm mercury. Then proceed to target systolic blood pressure below 130 and diastolic blood pressure below 80 if patient conditions allow it. In a frail patient, treatment and blood pressure goals should be individualized. Be wary of the lower is better approach given the J curve effect and possible increase in adverse events at very low diastolic blood pressures, less than 70 mm mercury. In summary, hypertension is highly prevalent among the elderly and is a major treatable risk factor for cardiovascular disease. Typically, elder patients have systolic blood pressure elevation with low diastolic blood pressure due to stiff arteries. Their main comorbidities make management very challenging, but the evidence gathered supports the benefit that can accrue with blood pressure lowering among the elderly. Lifestyle modification is very helpful, even when added to drug therapy. Remember to begin with low drug doses and titrate slowly. For those aged at least 80 years, 140 mm mercury to 145 mm mercury is an acceptable systolic blood pressure goal if tolerated. This ends our discussion on effective hypertension management strategies for older adults. We hope you have enjoyed the lecture. Don't forget to pass the quiz in our website in order to be awarded CPD credits.